I think we ended up talking a little bit about dumping syndrome. And just to kind of reiterate, this is a situation where, because of the small size of the stomach pouch that's left, the undigested food is like very concentrated, and so it will kind of come out of the stomach into the small bowel really fast, causing some kind of significant feeling of abdominal distension. Patients may exhibit dizziness, tachycardia. They may look pale and sweaty and have palpitations and complain of those kinds of symptoms. So it's kind of good to watch those patients that have had a gastrectomy and educate them about what this might be if and when they begin to have symptoms. In terms of colorectal cancer, this is cancer that involves the rectum and the large intestine. It's the third most common form of cancer and the second leading cause of death in the U.S. So it is extremely important. I can't stress that enough, that we educate patients all the time about this particular type of cancer and focus them on, preventive management, getting colonoscopies at the correct time frames. Risk factors that make people even more at high risk is if they have a personal history in the past of colorectal cancer, or if they have had adenomatous polyps that, on a prior colonoscopy have been found, or if they have family histories of colorectal cancer or family histories of having had those type of polyps. We've talked a little bit about inflammatory bowel disease today, and that the longer time period that somebody has that disease, they tend to have potential much higher risk for colorectal cancer, and particularly with ulcerative colitis, because it's specifically mentioned, and even Crohn's disease as well, but you tend to see it a little bit more with ulcerative colitis. In terms of physical inactivity and obesity, and we know those are risk factors for lots of types of cancer, and colorectal is no different. Diet, and these are just some types of dietary issues that tend to be more high risk. Patients that have a high-fat diet, or ones that eat red meat 7+ times a week, or eat processed meats. Smoking and alcohol consumption of greater than 4 drinks per week is also associated with colorectal cancer. Most all of the colorectal cancers are adenocarcinomas, just like we mentioned on the lower end of the esophagus. They very frequently end up with metastasis. Patients they may have a few symptoms, but they tend to not find these very frequently until they're fairly involved. And usually they'll just sort of have some unexplained weight loss, and fatigue might be the first sign that they're having, versus some actual GI symptoms other than weight loss. So usually for stage 2 or 3, patients are going to receive a type of chemotherapy to kind of control the tumor size. They may have radiation therapy done prior to surgery as a way to shrink the tumor size down smaller before they have to go in there. And sometimes that has to do with, the location of it, if it's invaded any of the surrounding structures. So it really just depends on size. In terms of surgical management, there's a wide variety of things that they can do. They can just do an excision of part of or all of the colon. And the types of colectomies that you may see. A hemicolectomy is an excision of half or less of the colon, and it could be the right side or the left side. So they take out a portion of the colon, and then they may either choose to do some type of an ostomy. They may take out portions of the colon and put the two ends back together, making a shorter colon. And then you may see this very extreme version of abdominoperineal resection, where the affected colon and the rectum is removed, and they take one part out through the top end through the abdominal incision and the other out through the bottom end, and the ileostomy that they have to have for that is always permanent because they don't have any colon left to really use. In terms of trauma, generally speaking, I won't read all this to you, but you think about oral and esophageal trauma that might occur in terms of just injuries, accidents. A lot of times with the oral things, you'll have fractures to the face, the nose, the jaw, or the maxillary bones. And you'll have a lot of soft tissue injury around the mouth. And anytime that occurs, anything close to the airway, and both oral and esophageal are, any swelling, any damage, any punctures, anything like that can significantly affect the airway. And strange as it may sound, esophageal traumas more commonly come because of diagnostic and therapeutic interventions, which is sad. A typical diagnostic endoscopy complication rate is 0.1%, so it's very minor. But if they are going in there to do some type of a therapeutic or treatment or take something out in doing an endoscopy, there's a complication rate of 10 to 15%. If the esophagus becomes perforated, it's a much higher mortality rate, and you have a 12 to 36% survival rate if it's found and treated within 24 hours, and after 24 hours that rate goes drastically higher. You can also have some caustic substances that you might swallow, other types of penetrating wounds or foreign bodies that might create an issue or a rupture in the esophagus as well. In terms of the upper GI tract, you're going to have mostly the typical things that deal with your breathing and your airway and maybe bleeding and swelling. You can also have loss of teeth and pain. You can have constriction to the esophagus and notice some hoarseness or changes in voice as well that would make you suspicious. And with lack of oxygenation, you may see folks having changes in level of consciousness to be aware of. Typical diagnostic tests, of course, they're going to do chest x-rays, CTs. For the esophagus, they may do facial x-rays as well. For the mouth, the jaw, nose, and those areas. The biggest things is to try to really control bleeding, repair any wounds if it's related to the esophagus. There is a way they can take part of a bowel segment and replace part of the esophagus in trauma, which is not often done. And then with the upper airway, in terms of the face, the nose, you're really looking at, how is that airway all the way down? And, if you've got fractures, how are those controlled? Also, trying to make sure that you have an airway. You may have to have an emergency tracheostomy done. again, stabilizing fractures. And then because of these type of traumas, you may have increased risk of infection, so the patients may need to be on antibiotics. They may have wounds that need to be managed or drained. And then you have to come up with some different way to kind of manage nutrition. Obviously, even with a mouth injury and esophagus, it may not be anywhere feasible to use a NG tube, for example. So they may have to go directly to a gastrostomy tube versus going through insertion. And if you should have orders for anything like that as a nurse to insert, always double check, because you don't want to be the one who's putting a nasogastric tube down and making further damage or perforations because of the condition of the structures as you go down. Hopefully this gives you an idea a little bit of the GI system. With the abdominal part, I will probably add another piece on here later. Thanks.